Good morning, my dear students. In this video, I'm going to talk in brief about antimicrobial selection and intrinsic resistance. Intrinsic resistance to an antibiotic confers a bacteria non-susceptible to that particular drug. And unless we know the intrinsic resistance, the mechanism, the drugs, and the bugs, we might end up in choosing the wrong antibiotic, which might not only prolong the duration of therapy, but also have an adverse impact on the outcome of the patients. Let us try with this, see this case. The first case, a 65-year-old man, diabetic, ventilated for 10 days post-abdominal surgery, and develops new fever with a rising temperature up to 39 degrees centigrade, along with purulent secretions, increasing needs for FiO2, and new infiltrate on chest X-ray. The initial empiric therapy has been ceftriaxone plus azithromycin on the suspicion of VAP. The culture grows, endotracheal of aspirate grows Pseudomonas aeruginosa more than 10 to the power 6 CFU per ml. Now the problem is after 48 hours, the culture grows Pseudomonas aeruginosa, and despite therapy, the fever persists. Now, why this treatment failed? Pseudomonas, we have to know, is intrinsically resistant to most beta-lactams except anti-pseudomonal ones because of low outer membrane permeability, which restricts entry of antibiotics. This typifies with ceftriaxone, or because of efflux pumps, or because of chromosomal AMP-C beta-lactamases. Therefore, in such cases, it is rational to stop ceftriaxone azithromycin, start piperacillin tazobactam or cefepime or meropenem pending sensitivities. We can consider inhaled tobramycin as adjunct in severe VAP, but always we should de-escalate based on cultures. So the point to remember is never use ceftriaxone empirically when Pseudomonas is a likely pathogen, like in a ventilated patient with prior broad spectrum exposure with on hospital for more than 5 days, etc. Let's look into the second case. A 70-year-old man with long-term Foley's catheter develops fever and flank pain. The urine is turbid, culture is pending. The patient is put on empiric therapy with nitrofurantoin and amoxicillin, and because the outpatient regime which was used is continued on admission. The culture result shows Proteus mirabilis. Now, what is the lack of response in this case can occur due to? Proteus species are intrinsically resistant to nitrofurantoin because of poor drug uptake and enzymatic degradation, and the commonly produce chromosomal beta-lactamases, which confers ampicillin resistance. So the rational therapy would be either IV ceftriaxone or piptas for severe infection. And when we have to step down, oral ciprofloxacin for step down, so if it is susceptible. So the key message is that always avoid nitrofurantoin in patients with alkaline urine or suspected Proteus, Morganella, or Providentia infections. Let us look into this third case, 68-year-old male with prosthetic aortic valve, low-grade fever for 2 weeks, blood culture is positive, and empiric therapy is with ceftriaxone and amikacin, typical for native valve infection, and the culture shows Enterococcus faecalis sensitive to ampicillin. So why can there be treatment failure? Now, intrinsic resistance explanation is provided because Enterococci lack high affinity penicillin binding proteins for cephalosporins, which confers them intrinsic resistance, and therefore cephalosporins should never be used as a sole therapy for Enterococcus. So the correct regime would be ampicillin plus amikacin or gentamicin for synergy if renal function allows the administration, or ampicillin along with ceftriaxone as a dual beta-lactam therapy. And for VRE, it is either we can give linezolid or daptomycin. So the key message is always avoid cephalosporin monotherapy when Enterococcus is suspected. Look into this case 4, a 25-year-old student with 7-day history of dry cough, sore throat, low-grade fever, and diffuse infiltrates on chest X-ray and minimum auscultatory signs presents. The patient is put on empiric therapy with amoxicillin clavulinate, but the course is that there is no improvement after 3 days and the PCR confirms Mycoplasma pneumoniae. So the intrinsic resistance is because Mycoplasma has no peptidoglycan cell wall. So beta-galactams and glycopeptides have no target. So Mycoplasma is resistant to such drugs which act on the cell wall. And the correct therapy should be to administer either azithromycin or doxycycline and fluoroquinolones for macrolide resistant strains. So in subacute dry cough pneumonia with minimal CREPS, think atypical and also avoid beta-lactam monotherapy. Let us look into this case. A 30-year-old with ruptured appendix, post-operative fever and foul peritoneal drainage is put on amikacin and metronidazole. The culture grows Bacteroides fragilis. Now, this again leads to partial treatment failure because amikacin is ineffective because aminoglycosides require oxygen-dependent transport into the cells, which is absent in the anaerobes. Anaerobes don't utilize oxygen and hence they are anaerobes. So only metronidazole provides coverage. So the rational therapy would be piperacillin tazobactam, carbapenem, or metronidazole plus ceftriaxone. And of course, as a source control, drain the abscess surgically. We also have to remember that carbapenem covers majority of the anaerobes except Bacteroides fragilis. So never use aminoglycosides as sole gram-negative coverage in deep anaerobic infections. Let us look into this case. A 60-year-old woman with renal transplant, headache, confusion, CSF shows lymphocytic with low glucose and high protein, is on empiric therapy with ceftriaxone, vancomycin, and dexamethasone. So as we can understand, this is an immunocompromised patient with meningitis. The culture grows Listeria monocytogenes. Now, the point of intrinsic resistance is here because cephalosporins poorly bind Listeria penicillin binding proteins and the standard meningitis regimen fails. So the correct therapy would be ampicillin plus amikacin for synergy for a period of 6 weeks, or alternatively, trimethoprim sulfamethoxazole if patient is penicillin allergic. So always include ampicillin for meningitis in elderly, neonates, or immunocompromised patients to cover for Listeria. Coming to this case, a 55-year-old hotel guest having high fever, dry cough, hyponatremia, confusion, chest X-ray shows patchy unilobar infiltrate and Legionella urinary antigen is positive. Patient is on empiric therapy with ceftriaxone and azithromycin. Now, again, the resistance we have to interpret in terms of the intrinsic properties. Legionella lives intracellularly in the macrophages, which the beta-lactams cannot penetrate, and thereby conferring them intrinsic resistance. So the correct regimen should be either azithromycin or levofloxacin, which has excellent intracellular penetration for a period of 10 to 14 days. So when hyponatremia or extrapulmonary symptoms accompany pneumonia, we have to consider Legionella and prioritize intracellular active drugs like levofloxacin. So we have to follow some principles. One is that we should know the intrinsic resistance before starting empiric therapy. The practical implication of following this principle is that it prevents blind beta-lactam use in atypical or anaerobic infections. The second principle is always interpret culture results in the clinical context. The practical implication is that if it is a situation like it is Enterococcus susceptible to ampicillin, that doesn't make ceftriaxone a choice. So you will have to understand the context. The ICU antibiotic policies should highlight these intrinsic gaps, and this is especially important for non-fermenters, non-lactose fermenters, Pseudomonas, Acinetobacter, Staphylococcus maltophilia, etc. And step-down therapy should respect intrinsic resistant patterns, and the practical implication would be to avoid oversimplifying to oral cephalosporins if the bug is intrinsically resistant. So as a take-home message, you remember a few examples that I cited. If the organism is Enterococcus, it is intrinsically resistant to cephalosporins. The preferred agents can be ampicillin, vancomycin, linezolid, levonadifloxacin. Mycoplasma is intrinsically resistant to beta-lactams, so the preferred agent is azithromycin or doxycycline. Pseudomonas is intrinsically resistant to first and second generation cephalosporins and macrolides. Preferred agents include piperacillin, tazobactam, cefepime, or meropenem. Proteus, Morganella, these are resistant to nitrofurantoin and tetracycline. So the preferred agent is ceftriaxone, ciprofloxacin. Anaerobes are resistant to aminoglycosides. So the preferred agents include metronidazole and the carbapenems. The listeria are intrinsically resistant to cephalosporins. Preferred agent is ampicillin. And the Legionella is intrinsically resistant to beta-lactam, so you should prefer azithromycin or levofloxacin. Thank you very much.